Welcome again, panel. And Paul, you're right down the end, but I'm going to start with a question for you. Well, one of the misconceptions is that genomics, as I mentioned, still belongs in the realms of research and discovery, but it's actually having an effect and it's in practice now. Can you tell us about the exciting field of pharmacogenetics? And please, have I pronounced that right?
Yeah, absolutely. So firstly, thank you for the invitation and the chance to come along and chat about the things that we all love. Obviously, I think we've made a big mistake not having a soundtrack to accentuate our profound thoughts as it goes along, so we'll have to remedy that for next time. Pharmacogenomics, why is that interesting from that point of view of genetics as this rare and unusual subspecialty that's developed? Well, it's a perfect illustration of the fact that genetics is not rare or unusual, and genomics is, in fact, as you'd expect, it's ubiquitous because it's the thing that defines us all as our underlying genomic sequence. And on top of that, one of the major planks of medical care is medications. And so most people, when they go and see a doctor, what they're expecting to get is a medication. And the reality is we know that every time a medication is prescribed, it's a little bit of an experiment. We think that most people will benefit from that medication. There'll be some people that definitely won't benefit from the medication. And then there'll be a small group of people for whom it will make things profoundly worse. And up until now, that experiment has just been going on, and we've just been saying, okay, well, let's see if we're lucky this time around. And pharmacogenomics is about the idea that we can do a lot better than that, because we have the genomic information that can personalise that, and we can say, actually, before we start, there is a way for us to know how likely you are to benefit from medication. And it's a really good illustration of the way that genomics provides that connection between the broader medical science, where we think about things in who benefits in a group, and it personalises it down to the point where we say, actually, with a bit more information, with your genomic information, we can make that a personal decision, and we can make it much more likely that you are actually going to benefit from the medication.
So, Paul, at what stage are we at with this? Is this being applied to people with specific diseases or ailments, or can I go to the pharmacist and say, hey, by the way, I want to get a test before I take this this opioid?
Yeah, so, again, it's a really good question, because it points out where the current barriers lie. The underlying science is all there. The technology that provides pharmacogenomic testing is the same as standard genomics. It's currently present. So the barriers are not around knowledge or detail or technology. The barriers are around the fact that it's something very new, and it requires a change in thinking, and it requires people to understand it better for it to make its way into general practice. We've been using it particularly in the setting of organ transplant, and the reason that we started there is it's because it's the pointy end, and we're using a lot of medications which are both expensive and toxic, and so the chance of problems is very high, and we know that absolutely everybody going through transplant is going to be prescribed a whole range of different medications. And so we're starting where the rubber hits the road, where it really does make a profound difference. But in fact, it's really as Melbourne Genomics has so often done, that's a demonstration of an idea, because the idea, in fact, could apply very broadly, and it's really just getting that idea across that's the most important thing.
So, and we'll move on to the other panellists in a moment, but is it being applied now in patient care for organ transplantation, or is it still at the experimental phase? So,
the word experimental is interesting in that sense. It's not an experiment. It is absolutely about translation. It's about saying, well, here is something we don't have to ask anymore, will this work? What we're asking is, can we get everybody involved? Can we put that across, translate it into clinical care? So the questions aren't anymore about ones of science. It's not a question of, does this particular genetic variant truly predict the drug level for this drug? We know the answer to that. The question and the reason why it's still part of research structures at the moment is because it's getting across those ideas to a broader group, getting the workforce involved, changing the structures in the hospital so that people are able to take this kind of information into account. That's where the research is at the moment.
And I will move on to the other panellists, but I guess this is really a statement rather than a question, but I assume when you've doing an organ transplantation, things are happening pretty quick. So it's not something that can be dwelt on, you know.
Yeah, no, that's absolutely right. Yeah, and in fact, that was one of the things that we learned through the transplant pharmacogenomics program, is that we weren't up to speed. And initially, at least half of the people were getting to their transplant before we could get the report into the doctor's hands. And so that was one of the things through the transplant program. We were just looking at this the other day, how much we sped up during the program to get those results out faster. But it's still something we'll take away from the program, that genomics, it has to be adapted to the time frame that we all work in the medical system. And so, you know, we need to keep working on those sorts of practical barriers.
Another practical barrier, and this is going to come up a lot today, is the fact that, or a misconception is the fact that people think it's just for rare disease. I mean, organ transplantation isn't rare, but Cathy, is it mostly for rare diseases? Is this true?
Firstly, I should also say thank you very much for inviting me along here today. This is really interesting, even though I can't really see very much and I feel a little dazzled under the lights. It's really great to come here and to have a chance to talk about something that I'm really passionate about. Rare disease is an incredibly important area, right? And the general tagline that we all say is that while many rare diseases are rare individually, collectively they're actually quite common. However, where genomics can make the biggest difference to society probably sits outside of rare disease and sits in much more common conditions. I'm a kidney doctor. 10% of the population over the age of 18 has kidney disease. By no stretch of the imagination is that rare. Kidney disease is the commonest reason that anybody in this country is admitted to hospital, and it's the single largest item on the federal budget in terms of routine healthcare, because many patients with kidney disease will progress to organ failure and needing dialysis to replace their kidney function, and that's an enormously expensive intervention. Genetic testing can help, as we saw beautifully illustrated in the performance earlier on. It can help a lot of people with kidney disease to understand why they have that condition, potentially to start precision therapies early enough in the progression of their disease that they do not need a transplant and that they don't need dialysis. And it can allow them to make informed decisions for their family to ensure that further generations do not have the same condition. So absolutely, genomics has stepped well outside of the realms of rare disease, and it's something that is useful to a vast variety of patients, whether they have cancers, whether they have a need for organ transplantation, whether they have kidney disease, or whether they're suffering from infectious diseases.
Can you, just putting you on the spot, Cathy, can you give us an example of how you're using it in your sort of day-to-day work, or have used it recently? Yeah,
so I run the paediatric kidney genetic service at the Children's, and we have offered genomic sequencing to every patient in Victoria who is eligible at this point in time. So we've actually done, like, every prevalent patient has been tested at this point.
What are the numbers with that?
I think we've tested 850 families to date, which has been possible because we have federal funding for the testing. We have federal funding because we generated the evidence, and Kushani Jayasinghe, who's sitting up here in the audience, in her PhD generated the evidence that showed that it was more cost effective to offer genomic sequencing early in the pathway of somebody's kidney disease rather than waiting until they progressed and offering more traditional diagnostic tools. And we use that information to persuade the federal government to fund it. And because we have funding, we have been able to roll that out to every child in Victoria who can benefit from it. And depending on the phenotype or the presentation that they come to us with, some of our groups will have more than 50% of them will get an answer through genetic sequencing. And that's particularly children who have blood in their urine. We've shown that in the Victorian population, around about 1 in 160 of our population has a genetic kidney disease that causes blood in the urine, and that probably contributes to our massive population prevalence of kidney disease in adults. And many of them are amenable to therapies that work, not precision, expensive MAB kind of therapy, but old-fashioned ACE inhibitor therapy that delays the progression of their kidney disease, doesn't cost very much money, and completely changes family outcomes.
So for half of those families that do have a result as such, or what is it like for them? And we'll talk a little bit more about the patient perspective later, but what is that like? What's the feedback you get from them?
So I'm fortunate to work with a genetic counsellor called Ella Wilkins, and that means that when we deliver this type of news to a family, we're able to do it in a way that is really patient-centred and family-centred, and that we can support them through that diagnosis. Because being told unexpected and unpleasant and disappointing news is always going to be traumatising, no matter how well we do it. But once we have delivered that information, and once that information is sunk in, usually we can start kids on a medicine once a day, and we can normalise that for them the same way lots of people take vitamin D or they take other things, and they just go on about their life taking their medicine once a day, coming to see us in clinic every 1 to 2 years, and knowing that they probably won't go into kidney failure at 50. They will never experience that.
That must be very rewarding, very rewarding. Norelle, I've heard you've been dubbed a superbug detective. You don't have your badge on today, but how is genomics being harvested? So we're sort of pivoting into a really different direction here, but how are you using genomics to help hospitals with the scourge of antibiotic resistance? It seems like movie stuff.
Yeah, thanks very much, Emily, and for sharing your story earlier. And thanks also for inviting me to be here today. It's such a pleasure to come and talk about genomics and fly the flag for pathogen genomics. So sometimes I feel like a bit of a black sheep at these gatherings, not because I'm unwelcome, but because we're talking about sequencing the DNA or RNA of pathogens, so bacteria, viruses and fungi that affect our patients. And so it is a bit like detective work in some ways. So when we sequence the DNA of these pathogens, we can use it for individual patient management, so similar to the human genomics approaches.
It's not an esoteric thing that you're doing up here, it's actually...
No, absolutely. It's something that we do quite frequently, more so in public health, but really we're on the verge of this being translated into practice in clinical infectious diseases. So we can use it for the individual patient management, but what we have been doing through some of the Melbourne Genomics projects has been using it on a hospital level, on a population level. So we sequence the DNA of the bacteria and we work out particularly the drug-resistant bacteria, so these really antibiotic-resistant bacteria that are really bad for our patients. They cause increased morbidity, mortality, hospital costs, long stays in hospital, lots of complications. And so we really want to prevent these. So the best way that we can do that is by getting knowledge, because knowledge is power, right? So understanding how these bacteria are being transmitted in our hospitals. And that sounds pretty scary if you're a hospital executive, probably, but it's actually a very proactive thing. So really understanding how these superbugs are being spread in hospitals means that we can give our infection control teams, we can empower them with that knowledge so they can put in interventions to prevent further transmission. And that's ultimately about improving patient safety and patient outcomes. And there's pretty good evidence from public health and a lot of other settings that also improves costs to hospitals as well and to health budgets in general.
So, is this work being replicated overseas as well, or is there collaboration? Because obviously it's not just a Victorian problem; it's across hospitals. And is there collaboration to try and actually figure out patterns within the antibiotic resistance?
Yeah, absolutely. So antibiotic resistance is a global threat, and it's definitely increasing. And there is a lot of work internationally as well as locally, but on how we can use genomics to understand antibiotic resistance and transmission in hospitals and in communities. A lot of large academic centres overseas, particularly in Europe and the US and Canada, they'll have their own sequencing services where each hospital can either prospectively sequence superbugs so they can identify problems before they see them, before you have big outbreaks and they can prevent them, or they start sequencing early when they suspect an outbreak. So it really is that detective work.
So are we at the level now, Norelle, where, and correct me if I'm wrong, so a patient comes in with an infection which can't be resolved. Are you stepping in at that point, or are you still sort of not quite that close to being able to resolve individual patients?
Yeah, there's a few different applications. So for individual patients, that's a little bit more, there's a little bit more work to go there. But there's a lot of development work happening in rapid genomics of patients with severe infections. So you can very quickly identify what antibiotics will and won't work. So that helps both with the management of individual patients, but also antimicrobial stewardship. So making sure we're not overusing our super high-powered antibiotics, and we're saving those for the patients who really need them.
It's almost like there's a little bit of a crossover with Paul's work in terms of you talking about the antibiotics that you're making sure that the right ones are being prescribed. So there's an overlap there in some ways.
Absolutely, and there's also the same issues that Paul's seeing with the science is there. It's really about the application now.
Yes, yeah. Well, it's all very impressive what you're doing, but the elephant in the room, well, actually it's not going to be, we're going to bring it right out later when we talk about it, but particularly in healthcare, nothing good comes cheap. So I assume that most genomic programs are exorbitantly expensive, that it's really just out of the realms of the constrained budgets at the moment. Now I can see a reaction there from you. Cathy, what do you think? Is it too expensive?
Healthcare is really expensive, but I don't think genomic healthcare it's certainly not any more expensive than the alternative, and then frequently what we've shown is that it can be cheaper than the alternative, and I think that's the really important part. What is difficult and what is tricky these days is not the sequencing and the figuring out and all of that, although the work that both of you are doing sounds like that's very tricky. For me, what's difficult and what has been the most fun to do has been figuring out how to teach the workforce to utilise genomics effectively, how to set up our work streams effectively, and how to make sure that silly things like being able to print out a consent form, get it signed and scanned back into the chart are not the barrier to a patient actually receiving a test. And they are problems that are best solved working at a much higher level in the hospital system. They're not something necessarily that at the coalface we're able to do. It's setting up those systems and empowering our workforce to actually use genomics effectively. And that's something that I think Victoria leads the world in doing. And that is an area where other countries are learning from what we are doing here in our state in order to improve their processes, to make sure that patients actually do get, and it's a cliche, but the right test for the right patient at the right time, selecting that out and being able to deliver them the test and the result in an efficient way. And so that is not expensive. Getting your processes in place saves time, saves money across the board.
Mm-hmm. And Paul, are you begging for money most days? Or
I obviously wouldn't say no. But no, I completely agree with Cathy. I've been around long enough to have been there in the days when, we did genetic tests and they cost thousands of dollars, and the first genetic test that I did took a year to come back, and so you literally made the appointment for the same day.
Do you reckon with that? Like, what year was that? Do you reckon around
that
about?
was the early 2000s.
Wow.
Yeah. And I think, of course, like all things, it takes a while for people to realise that things have changed very profoundly. And today, the genomic sequencing that we do is not more expensive than very common interventions that happen within a hospital. It's very much within the realm of normal testing costs. On top of which, it has this incredible unique feature that if most of the testing you do tells you about what's going on today, and tomorrow it will be different and you've got to do the test again. But genomics has this incredible feature that if you do the genomics properly, it is always, your genetic code essentially is the same from every time that we do it right through. And so it has this incredible efficiency that it gives you all the information that you want. You can go back and ask it more questions down the track, but you don't have to go back and redo the test from the very beginning. And so this is something which is
it's like
unique
baseline
in
data.
Yeah. I mean, it would be better to think about it as being akin to your medical record than akin to a biochemistry result.
And Norelle, something like antibiotic resistance and superbugs, it's hard for policymakers and those who hand out the money to kind of get their heads around it, because it's not cute little kids with kidney disease and stuff like that. So I guess how do you make that argument that it's yes, we need funding, but it's not exorbitant, it's not too much, and it's actually going to have a value for you.
Yeah, well, I find my bacteria cute, but I'm sure most of you won't. It's quite different, I think, because we're looking at a kind of hospital level or a systems level or a state level or a population level. So we're not talking about the individual patients in this particular instance. And so that's really something where we have to show value for money. And often I feel like our hospital budgets are a little bit segregated. So sequencing costs are in pathology, but actually your savings are going to be outside of pathology. So it's really about taking that high-level view, I think, on the value of preventing future infections. And a bit similar to public health and COVID, it's very hard to prove what you have prevented, but there are actually some really good models to show cost effectiveness of sequencing, but it does need to be evaluated or I guess kind of streamlined for each hospital's situation. And so there's a little bit more work to be done on that. But in general, the movement is towards hospitals investing in this or health systems investing in this on a state or a Commonwealth level, to actually empower our infection control teams to prevent future infections and improve the patient safety.
And while you've got the mic there, COVID, which is something we all want to put in the past, but unfortunately we can't. Did your work feed into that at all? And can you tell us a little bit about, if it's not too triggering for everyone, can you tell us a little bit about your work with that horrible virus?
Sure, yeah, it is a bit triggering, but because my husband's not here, I'll tell you the story that as I was doing my PhD and doing one of the early superbugs projects, he said, but what are you going to do at the end of it? Who's going to need you to do genomic superbug detective work? And then along came COVID. So yeah, absolutely. This work fed into a lot of the COVID work. And one of the, whilst I was managing the statewide genomic surveillance for COVID, we also had a lot of requests from hospitals about healthcare transmission. So early on, we really didn't understand how COVID was transmitting, and there were a lot of questions about safety for staff and whether we had the right PPE. And so we used very similar methods to our early superbugs work to track healthcare transmission. And that, I think, it changed a lot of infection control policies, fed into some of the work around aerosol transmission of COVID as well. So yeah, it was a lot of work, but it was
How
great.
did it feel during that time? Because obviously it was a heightened time. Was it feeling like sort of eureka moments and aha moments for you personally?
Yeah, absolutely. I guess outside of the hospital work, the eureka moment was not great for the state, but good, I guess, for genomics, identifying the source of the second wave of COVID. So that it wasn't possible without these genomic methods. So the uses of them are really broad, from single patients to hospitals to whole communities.
Fascinating. I mean, fascinating and quite scary at the same time. Going, oh, we found it. Oh, this is unpleasant. But yeah. Was it?
Yeah. Yeah, absolutely. I remember it vividly. It was 10 o'clock on a Wednesday night, I think. And yeah, phone calls to each other to make sure we absolutely had it right before going to our health department.
Wow, that's amazing. Well, congratulations on that. To bring us back to the present, Paul, I'll come back to you, and I know I've heard a little bit about the use of genetics in cancer treatment per se, but can you tell us about, I guess, some of the most common work that you do in that field yourself?
So yeah, the field of cancer, really, there's two major components, and this is a great illustration of the way sort of the common technology around genomics provides these different pathways, and each of us here are talking about a similar sort of thing, a different application. So in the cancer field, you have two genomes to work with, the patient's genome and the cancer's genome, and in both cases it tells you really important information. So I tend to be more on the patient side. I'm working with the patient's own genome, and that's trying to understand who's at risk in the population for cancer, and so using that information to try and personalise our risk management strategies and improve that, so that we're either preventing or intercepting cancers, or if they're going to occur, we're picking them up at the earliest possible stage. And then the other side, when we're dealing with the cancer's own genome, what we're looking for is its vulnerabilities. And so, of course, this is the huge area of targeted therapies, which has absolutely exploded in the last few years, in which there was a good illustration in the presentation right at the beginning today, where the genome can tell you some really vital information, tells you a lot about the identity of the cancer, but if what you're really looking for is you're looking for a target, a way in for that cancer, and it has profoundly changed the outcome of a number of types of cancer, and that's only sort of increasing over time. And so it's an example where we'd say that line that was in the play this morning about what it's like to practice before and after X-rays. I think this is a perfect example. Oncology, there'll be the pre-genomic oncology, and everyone will say, well, that was tough going, but once we've got the genomics, then it's a different story altogether, and we just practice differently now. What,
I guess, Paul, made you so interested in this field and go down this path, really?
I've got to say, it wasn't ever tricky for me. The first time I really understood the idea that we are walking around with some of the most profound information about who we are and our future health, and it's in every single cell in our body, literally everyone is going to leave it on their seat today, then it was just, well, why would we not want to know that? Surely that's the most important thing. And once you've got that information, and for all of us who've been interested, it's always been a case of just saying, oh, we're not quite there, it's coming. And now we're actually at that point where we can say, actually, it's not coming anymore, it is actually here. And as we've all mentioned, the barriers are no longer about being able to get hold of that information or understanding what it means. The barriers are simply being able to put it out there and to use it in clinical practice. And so, I've always found it the most exciting thing, and I'm always think I'm extremely lucky to have lived through the age where it's actually come into being. Yeah,
without divulging, obviously, or going into patients' privacy, is there a certain cancer or group of cancers where it really has been quite mind-blowing in terms of what you know about it or how you can tackle it now?
One that did get mentioned in the play this morning is a really good example. So melanoma, which is an Australian success story. We lead the world in melanoma. It used to be that apart from the very earliest stages, melanoma, the treatments were extremely limited and the prognosis was very poor. And to see melanoma spread anywhere was essentially, I'm afraid that's game over. We're into sort of life-extending therapy and that's it. Today, melanoma is absolutely treatable. Even recently, people have shown that even quite extensive melanoma, including metastases, brain metastases, so even if it's spread to the brain, some of those people can be cured with the current targeted therapies. Wow, that's amazing. And that is, utterly, profoundly different to the way that we've practiced for the rest of history, basically.
Oh, thank you, Paul. That's amazing. It's, people, melanoma, if you don't have one yourself or you don't get one yourself, you know someone who has, so it's amazing work. It all is wonderful, but I guess the reason we're here is to try and take it from what you're doing and make it more common. So I'm just going to start with you, Cathy. What do you think is holding genomics back from being more widely used? What are those pain points for wider adoption, or what keeps you up at night or frustrates you?
To be honest, I don't think genomics keeps me up at night anymore, because I think in my specialty, in paediatric nephrology, we're on the other side of all of this. We have completely mainstreamed the use of genomics in paediatric nephrology. My colleagues who are general nephrologists utilise the testing on a regular basis. They understand the results. They communicate those to their patients and to their families, and they use the technology in the same way as you would have needed a subspecialty clinic to go to 10 years ago. So if anything's going to keep me up at night, it's how can we get that from our specialty, from kidney medicine, out to other specialties that have not begun this journey yet. And what I really hope is that everybody doesn't need to go down a 10-year journey of slowly getting there and educating their workforce and putting all of these supports in place in order to help people to use this testing appropriately, but that they can learn from where we are and can maybe just start from a different point.
Are you already helping other organisations, and you don't have to name them, or the people overseas asking you to, hey, can we replicate what you've done?
Absolutely, yes. So I work quite a bit in Europe and in the US and in Canada with different organisations, helping them to basically take all of the resources that we've created and take them as their starting point. Because as we've created all of these resources, we've been supported to really have no ownership over them, no ego, no saying this is my way of doing it, but just saying we've created this resource, please use it, please improve upon it for your cultural setting, and go forth and make this something that's useful for patients everywhere.
Yeah, so you're leading, I know most researchers and medical specialists are very, very modest, but it sounds like you're leading the way.
I don't think I'm leading the way, but I think Victoria is definitely leading the way, and I think nephrology or kidney medicine is definitely flying a flag for how genomics can change our patients' lives and can prevent the worst end of kidney disease. And I think that's something that is easily translatable to any healthcare setting.
Yeah, great. And what about you? In your area, what do you think is holding it back from being more widely used? Or if it's not, then why is it being adopted so well?
Yeah, I think there are still a few barriers that we need to address, and as Cathy and Paul have said, workforce is definitely one of those. So there's a lot of people to educate, but I think what I've seen over the last 7 or so years that I've been involved with genomics is a huge increase, and that kind of 10-year view is amazing. So my first foray into genomics was in 2011 when I published a paper on 4 genomes. It's my most highly cited paper, but now if you actually couldn't get that published because that's just ridiculous. The numbers, the ability of us to sequence, the technologies have come so far. So now it's about really at that pointy end of implementation. So it's about getting the speed as fast as possible. And that can probably only happen in hospital laboratories. So that's a big leap, going from a centralised laboratory where you send something away and sure, we can get results back in about 5 to 7 days, but our clinicians and infection control staff say not quick enough. We need it quicker. So to do that, we really have to make that leap from centralised sequencing to sequencing in labs.
So where is most, and this is a naive question, but where is most of the sequencing done now in Victoria? Is it centralised, or or does everyone have their own little?
So pathogen genomics will be slightly different. So in Victoria, it's mostly being done centrally at the public health lab at the University of Melbourne, where I work. But there are a few hospitals who are starting to get into genomic sequencing for pathogens, mostly in a research setting to start with. Yeah.
And I guess it's space, as we'll probably hear later today, in a hospital environment, space and resources are at a premium. So you have to make a pretty strong argument to say, I'd like a little lab over here, please.
That's true, but there are amazing things like a little a MinION that is the size of a USB key that plugs into a laptop where you can sequence bacteria.
Wow.
It's amazing stuff. So things have come so far, and in fact, you can, if you have a patient who's got a positive blood culture, you could potentially put some in there and get results within 1, 2, 3, 4 hours. Just incredible. And so it's really about getting those technologies closer to the patient to be able to do things in real time and get those results out and get them acted on, because people because we've got the evidence base behind them and people understand them and they can trust them. That's where we're at.
And that trust is another issue which will come up today in terms of bioethics and what we do with the information and where does it go. Paul, are we at the point where we can we have those parameters in place around privacy and ethics, or is that we're still sort of playing catch up with that as well?
Well, I think it's a conversation that never ends. So no one should ever feel that they've solved the problem of privacy and confidentiality and many of the broader social and cultural issues that go around genomics. It's a dynamic conversation, and we should always be having it, and we should always be listening to the different views that people have. Having said that, of course, we've come a long way, and today, first of all, on our side, we take this incredibly seriously. Everyone's very conscious of the fact that just as genomic information is so critical for all of these uses, it's also incredibly sensitive and something that people deserve to feel that information is being treated in the most sensitive and protected way. But also we know, and we had a lovely illustration of this in the transplant program, where we went back and asked everybody who'd been in the program at the end of it how they felt that their involvement in the program had gone, and whether they felt that they had benefited from being in the genomics program. And there were two questions in there. One was, were you aware of how your doctors had used the information to your benefit? And then the other one was, would you recommend other people being involved in a similar program? And there was this lovely mismatch that most people had no really strong ideas about how the doctors had used the information. As you'd expect, it's quite a complicated thing, and they sort of crossed their fingers and hoped that it was used in the right way. But then on the flip side, everybody recommended it everybody said, yes, I would recommend this to a relative. And so what it shows is there's both a great enthusiasm and a great trust out there. People want this kind of information. If there is a way to personalise their care using their genomic information, the vast majority of people are extremely keen for that to happen. And so it's saying to us, actually, the community is not a barrier. The community is ready for this, but we must do it in a way that we maintain that kind of trust, and that we take everybody with us. And I think that's where the impetus comes back to us to keep that conversation going.
Because there's a lot happening in the space of AI and other technologies that's frightening people. So like you say, it's an ongoing challenge, isn't it?
I often make a flippant joke with people when we're going through the consent form that we won't be sending your DNA to China, and people laugh, but then they also go, well, that's good.
Oh dear, no one would want to see my DNA anyway, I don't think so. On that point, obviously community education is going to be a huge part of this, as well as clinical education. How does it work in, Cathy, for you? Is it something that's done on a one-to-one basis, or do you have an education program at the hospital at the moment?
We certainly have a number of different education programs at our hospital, but I also run a dedicated kidney genetics education program that has been offered to every nephrologist in Victoria, has been rolled out across Australia, and has been run around the world. We started it as face-to-face stuff and got federal funding as we were headed into the triggering pandemic, so that we were able to use the funding to turn it into an online platform.
I was going to say, how does it work?
Yeah, so it's an online platform. You go through about 5 different modules. It teaches you about genomics overall, and then very much kidney genetics in particular. And it's got this sort of choose your own adventure, adaptive learning framework, so that different people will learn different things from it. And then we finish it off with a capstone workshop where we go through. It's all very much case-based learning. I spent some time a couple of weeks ago in South Africa delivering the same program there to aspiring kidney geneticists across the continent. Really fascinating to meet people who are at the coalface of paediatric nephrology in Malawi and in other countries where they're really resource deprived, but where genomics is affordable and a kidney biopsy does not exist. And so they are able to use genetics in a very different way to the way in which I think it's thought of in a resource-rich environment, where we think of it as, as expensive and nice to have. But if you are facing a patient in front of you who needs a test but will have to go down the market to buy a biopsy needle, to buy the gauze, to buy all of the anaesthetic supplies, or you could send a saliva swab overseas and get the same genetic result, then that becomes a really different value proposition for healthcare services. And the education programme and the resources that we've developed in Melbourne Genomics have actually helped to prop up those sorts of services and get them started at a really high level.
That's fascinating, and I guess from the patient point of view too, I know what I'm going to choose every day of the week. So, that's amazing. And what's the feedback you're getting from that education offering? Are people taking that and then further extending, or are they be able to implement their own?
People are implementing things straight away, and by and large, what people at that particular group came and asked was, can I share this with people, or do I need some sort of agreement from you to share it? And I was like, share away, use what you want. Here's my email address, get in touch if I can help in any way. Just very happy to deliver this again for you if you want it. People are using it on the ground straight away.
It's very altruistic. Is that something that drives you, Cathy, that helping, I guess, spread the word and
Well, I think I'm a paediatrician, so I want children to have a normal, healthy life, and I don't want them to be sick in childhood. I want them to have the chance to grow up and go to school and do all of the things that they're meant to do without visits to doctors and needles and medicine. So whether they're in Malawi or in Melbourne, it doesn't matter to me. I want them to be better everywhere. And if I know how to, I'm probably quite a pushy person. So if I know how somebody can make somebody else's life better, I want them to understand how they can do that.
Hospital admin must love you. Okay, moving on. I keep checking my phone, not for messages, but because I can't see the time on my iPad. My eyesight's so bad. We have a couple more minutes because it'll take us a while to get up here and for morning tea. So for all of you, a final message or piece of advice to the health leaders in the room that you think is important for them to know, or a misconception perhaps that you can leave them with, that's something that you've corrected for them. Yeah, if you had your chance in front of the big boss, what would you say directly to them now?
Well, I think whenever you're sitting in front of the big bosses, then you're going to be talking about funding, and what I'd be saying is simply that idea that actually this is a pathway to efficient, reduced costs, better care. It's not another expensive add-on to the healthcare system. It's actually about taking away some of the problems that we've always had. Lots of Cathy's mentioned procedures that can be removed. I've talked about medications that don't need to be prescribed or could have been improved. These are all refinements that ultimately are money-saving ideas. We know, healthcare is extremely expensive. You only have to turn that dial a little bit in the direction of efficiency, and you start to make really big savings. And with the way that the cost of genomics has come down, it's reached that point where the needle is pointing very much in the direction of cost efficiency. And so if I've been talking to hospital leaders, I'd be talking about actually this is very much in your best interest now. This is actually a pathway to achieve the same things that you want to achieve, but it's actually at the same time improving care and adding this level of personalisation in.
Great, Cathy.
I mean, I would echo everything that Paul says. I think we're all singing a very, very similar tune here. I guess if I would add anything to that, it would be that genomics is most useful early in the course of disease, not, we think from the dramatisation that we had here earlier on, not after you've already had a few rounds of chemotherapy for what's thought to be a sarcoma, but like as early as is possible, allows you to make the right decisions, to not have side effects from drugs, to not have complications of procedures, and to try and prevent the outcomes of the condition progressing as early as possible. That if we really want to save the healthcare system dollars, and we really want to improve outcomes for patients, which is obviously our primary concern, then delivering genomics early in the piece is the most important thing, not when they get a really long way down the road.
Great. Norelle?
Surprisingly, I have quite a similar message, and that the ounce of prevention is worth whatever it is of cure. I think it's an investment to improve patient safety ultimately, and the science is there, and it needs to be as close to the patient as possible, and that's why investing in your hospital is is worth doing, so that you can get the rapid turnaround times. You can make those decisions early, albeit either for individual patients or to investigate, stop outbreaks happening before they occur. So yeah, it's just about investing that money early, and ultimately saving more infections.
Wonderful. Well, thank you, Paul, Cathy, and Norelle. You've opened our eyes really to the breadth of applications from parts of Africa to to obviously the COVID epicentre here in Melbourne. And I think coming some way to curing those misconceptions that it's too costly or too niche. And it sounds like you're all very passionate about this. Are most of you hanging around? Are you hanging around for some of the day, most of the day? Excellent, excellent. So they'll all be here for most of the day and later on at the round tables. So you can ask your burning questions to the panel now, but can we please give them a huge round of applause?